couple folks in the room. Welcome to CCR and Pulmonary Part 1, really important in terms of looking at the foundation of pulmonary mechanics. So let's begin without any further ado. Want to remind you that the role of the pulmonary system is to exchange gas. And in order to exchange gas, you have to work. We talk about that as the work of breathing. The work of breathing is when you are visibly evaluating your patient or using pulmonary function studies to determine the amount of effort that the patient is requiring to move gas in and out of the lung. And two things have to be overcome with gas movement. The first is the compliance of the lung. Now, in general, when we talk about lung compliance, we talk about lung compliance as measured by the most important surface area of the lung, and that would be the alveoli, which is where all gas exchange takes place. So really, really important for us to appreciate that we look at the alveoli as the indicator for compliance. 16 million alveoli completely surrounded by blood vessels and inside the thoracic cage. We talk about lung compliance primarily as an indicator or a measurement of alveolar opening, or what we call alveolar recruitment. Secondly is airway resistance, and that is primarily measured for the conducting airways from the trachea to the bifurcation to the continued separation of the pulmonary bronchi. And as they move out into the periphery of the lung architecture, and airway resistance is what opposes gas flowing in and out of the lung. So lung compliance for us, we're not going to be respiratory therapists here. Lung compliance for us is about alveolar recruitment, and airway resistance for us is about the diameter of the airway that is conducting gas flow in and out of the lung. We're going to refer to this a lot when we talk about ARDS, which will be the main product of questioning. And we talk about it a lot. When we refer to lung compliance, we use the P plateau pressure. And when we talk about airway resistance, we use the peak airway pressure. Both of those require that you are mechanically ventilated. So we're not going to actually, everybody doesn't have to be an expert in pulmonary function studies, pulmonary function testing, but on a critical care ward and in a critical care test, we have to understand the indicator of lung compliance, which is alveolar recruitment, measured as P plateau, and the indicator of increased or decreased airway resistance, which is measured by the peak inspiratory pressure. So more about that a little bit later, really important to remember. The lung compliance itself, the alveoli, is actually determined by the state of the alveolar wall and the fluid that surrounds it, as well as the thoracic cage. So we're kind of done with that for this moment. We'll talk a lot more about it later. What we really want to think about initially is what kinds of things affect airway resistance. So airway resistance is under autonomic nervous system control, and that's the balancing of parasympathetic and sympathetic. Okay. Now just remember that sympathetic stimulation actually promotes airway dilation, and sympathetic block promotes airway constriction, and parasympathetic is exactly the opposite. So always really important to remember those balances of sympathetic and parasympathetic nervous system, and to also consider the role of one of the most important inflammatory mediators as it relates to airway resistance, and that is the release of histamine. Now, all of us can appreciate that. We can understand that allergic responses that cause airway narrowing are particularly due to an overt overflowing histamine response, which then causes upper airway constriction, no gas flowing in or out. And it is, of course, part and parcel of what we see with patients who have acute asthma. So then we move to basic pulmonary physiology and what really controls sympathetic and parasympathetic nervous system stimulation. And that really brings us to the respiratory control center, which is primarily located in the medulla oblongata. So very, very important for us to appreciate that just like your cardiac pacemaker, you have a respiratory pacemaker, and that respiratory pacemaker is primarily responsive to the presence or absence of carbon dioxide, primarily responsive to the presence or absence of carbon dioxide, and secondarily responsive to the presence or absence of oxygen or the overall blood pH. Our central chemoreceptors, which are the primary responders, are very significant in terms of their response to the presence or absence of carbon dioxide. So presence of carbon dioxide, very importantly, greater than 40, presence of carbon dioxide typically will stimulate a more rapid respiratory response. Once the CO2 gets above 70 or 80, you can then, of course, see very significant depression in the central nervous system. The oxygen receptors are located primarily in the delivery areas, the prime delivery areas, which are to the brain and to the heart, so located in the carotid. They're located in carotid bodies or in the aortic arch and are responding to the absence of oxygen or the acidosis or alkalosis of the blood pH. So really important to look at this balanced approach to the respiratory pacemaker control, remembering that CO2 is the primary chemoreceptor, secondarily PaO2 and blood pH. These are really important in terms of stimulation and activation. So critically and profoundly important to understand the presence or absence of these receptor sites and understand where they reside and how they respond. Now, those receptor sites. Hello, my darlings. Please mute yourself. Please mute yourself. You have a lovely baby who is not muted, and that would be Gaprek. I'm going to mute you now, Gaprek. Lovely baby, very sweet and sounds adorable. Okay, guys, always remember to mute yourself. Thank you so much. Okay, so we're just looking at this visually, right? We're looking at this the cortical control, the medullary evaluation, the stimuli that stimulates through the hypothalamus, those respiratory centers, and as well as the central chemoreceptors, the peripheral chemoreceptors, that all are going to be responsible for our control of breathing. Okay, all right. So again, just taking a look at that, remember you have peripheral chemoreceptors, you have central chemoreceptors, and typically we're going to say CO2. It's really the presence of acid, but it's CO2, and how much your lung tissue is being stretched, how much oxygen is being utilized at your tissues. So it's a multifactorial control of your inspiratory center. Now let's remember that the purpose of this respiratory control, and we have to always appreciate, is to conduct air to the alveoli where gas exchange takes place. So when we talk about respiration, it's really important for us to remember, we talk about respiration in the lung and we talk about respiration at the cell. And that's really important to remember. When we're talking about the lung, we're talking about respiration. It's the process of oxygen actually being transferred from the percent of oxygen that's in the air into the alveoli and ultimately into the blood where it can be delivered to the tissue. And then CO2, which is in a relatively high content in the blood, moves from the blood to the alveolus and out to the atmosphere. Okay, so that makes a lot of sense to us. We're going to monitor your oxygenation by endpoints of oxygen, like your SpO2 or your SaO2 or even your PaO2. We're going to monitor that oxygenation, but we can monitor CO2 not only from your blood, but also from what's been excreted in the expired air. And of course, that's the end-tidal CO2. And when we talk about respiration and gas exchange, there are going to be three really important perspectives here. These three important perspectives actually come underneath a great grandmother name, and that would be ventilation and perfusion. So we're going to think about the processes of gas exchange, which actually ventilation to perfusion means gas and blood should always meet. That's known as VQ, ventilation to perfusion. Almost in a 1-to-1 ratio, the gas you breathe should match with the blood that flows by in almost a 1-to-1 ratio, and that's called ventilation perfusion. Okay, so really, really important for us to appreciate this, because if we say the function of the pulmonary respiratory system is gas exchange of oxygen and CO2. It makes perfect sense to us that we are always going to try to optimize this by increasing the oxygen to the alveoli and by increasing the blood flow past the alveoli in the pulmonary circulation. That is our goal. And we're going to evaluate that process, most particularly by blood gas, but we can also evaluate by SpO2 or SaO2 and end-tidal CO2. But primarily, we're going to evaluate it by a blood gas analysis. And that's really going to give us good information about our lung integrity and the integrity of ventilation, which is the movement of air in and out of the respiratory tract, and is most particularly related to expiration, which is CO2 exhalation, and oxygenation. And oxygenation, what's always important to remember, it always occurs here at the alveoli. So the alveoli are critically and profoundly important in terms of oxygenation. And that's why so much of your ventilatory strategy is about opening alveoli. You do that with CPAP, you do that with EPAP, you do that with PEEP. That's what opens up your alveoli, and that's how you promote better oxygen exchange. So sorry for that, guys. All right, so really, really profoundly important when we're talking about our patients and we're thinking about how this is operating. Something that there's always a lot of discussion about, and in my recent test, which was probably the last recertification, so probably 4 years ago, or 3 years ago, there was a question about this, and the question is, what does dead space mean when we're talking about the lung? So I want to make sure we don't get hung up on this. This is pretty straightforward. Dead space means where there's gas that does not communicate with blood. Okay, so in my airways, my conducting airways, the anatomic airways, those airways do not communicate with blood. So that is considered anatomic dead space. My ET tube does not communicate with blood. That's considered dead space. My ventilatory tubing does not communicate with blood. That's considered dead space. Dead space is surface areas that are not communicating with blood. So it's very normal to have anatomic dead space, meaning tubing, ET tube, conducting airways, because the only place in the lung that actually communicates in gas exchange, which means communicates with blood, are the alveoli. So we're not worried about anatomic dead space. We may try to overcome that with our method of ventilation. We have to overcome dead space. We think about how hard it is for patients to take a breath when they're intubated. Without any kind of support, we use pressure support to overcome the dead space so that it becomes easier for the patient to move gas. Oh, my goodness, I'm so sorry. But when we talk about alveolar dead space, that means that now we have lung units that are not communicating with blood. Okay, now if it's dead space, unlike this little statement right here, if I increase alveolar dead space, typically what that means is the alveoli has received gas, but there's not adequate blood. Dead space means gas is there and blood is not. That's what you want to remember. And it's normal to have anatomic dead space. We all have anatomic dead space. It is not normal to have alveolar dead space. So the most common cause of alveolar dead space, when the gas is in the alveoli, but there's no blood flow past, is not what I've listed here. And I'm so sorry. It's pulmonary embolism. Gas is there, but blood is not. It's overdistension of the alveoli. Gas is there, but blood is not. Okay, so I want to remind you that the way you've been designed is to match gas exchanging units with blood flow by, okay? And typically what we're going to say is the gas is typically around 4 liters a minute and the blood is around 5 liters a minute. And that means that your VQ match is normally around 0.8. 0.8. That's the optimized VQ match. The place that this happens the best VQ ratio is actually in the center part of the lung. So if I look at my lung, I hope I have a picture here. Okay, I may not have a very good picture here, but I'll just use my cursor. So I'm standing upright, and what I'm going to tell you is the base of my lung, more blood is in the base of my lung than gas is. So that means that in relationship, ventilation to perfusion, the perfusion is higher and the ventilation is lower. So down here, I would have a low VQ match. Up here, I'm going to have more ventilation than I have perfusion. That's in the apices of the lung. So I'm going to have higher ventilation than I have perfusion. That's going to be a high VQ match. And for the majority of healthy lung, the best place to match gas and blood is right in the middle of the lung, in an upright lung, okay, where V and Q are matching. Okay, so this is one of the reasons that we talk a lot about position therapy in patients who have lung dysfunction. You always want to shift their VQ match. That's what you're doing. Okay, so unfortunately, I don't think these guys can see me, which is, I'm very sorry. I'm not sure how it got all turned around. So let me just see if oh, here we go, presenter count. So now you can see me. Okay, so what I want to remind you is your lung is divided into three basic surfaces. Gas at the most independent, a lot more gas at the independent lung. So that for me would be in my apices, a lot more blood in the base of the lung. So for me, that would be down at the bottom of the lung. And the best gas exchange takes place in the middle. Okay, so optimized VQ match is in the middle part of the lung. That's known as the zone 2. Now, if I'm laying flat on my back, or even at 20 or 30 degrees elevation, the whole posterior surface of my lung is where the majority of blood flow goes. And the anterior surface of the lung is where the majority of gas goes, which is why we change patient positions aggressively, and which is why proning is an early recommendation when you have patients who have failure of gas exchange. Okay, does everybody understand that? Gas goes to the independent surface, blood goes to the dependent surface. So never allow your patients to stay in one dependent-independent ratio for any length of time. Does that make sense? Make sure it's clear to you about why this is important. Okay, gas always goes to independent more aggressively. Blood always goes to dependent more aggressively. And you cannot allow your patients to stay in one position for any length of time, because they'll have that separation of blood and gas. Okay, so again, really, really important when we're thinking about this relationship, we're thinking about how we evaluate the lungs, how we manage our patients, what it is that we are attempting to do with our patients, and why position therapy is something that's going to be really important. And when you have patients with failure of gas exchange, one of the most important things you can do is change position. And on your exam, it won't be turn your patient every 2 hours. It will be, should you prone your patient? And yes, you should prone your patient if you have poor gas exchange. And you should do that early and aggressively. Okay, so just looking at the lung, remember here is your main conducting airway. It bifurcates in the right and left brain, pulmonary stems, and they further divide. And actually, this is a lovely artist rendition, but it divides by 16 each time that it divides, and always terminates in what we call the respiratory bronchiole. The respiratory bronchiole leads to the sac of alveoli. And what's really important about your alveoli, what's important to remember, is that the alveoli is, as you see here, and again, it's just an artist rendition, completely surrounded by blood vessels. Those are the pulmonary capillaries. And this, of course, is where gas exchange takes place. So O2 goes from alveoli into the blood, and CO2 goes from blood into the alveoli. So here's your alveoli, here's your blood, right? And when you maximize gas exchange, oxygen will move to blood and CO2 will move out of blood into the alveoli. So my number one goal is I want to optimize the oxygen in the alveoli. So how am I going to do that? I'm going to do that by increasing the partial pressure of oxygen, that's my FiO2, and also by distending my alveoli. So I'm going to do that with PEEP, and other mean airway pressure strategies, but for our purposes and for the exam, PEEP. PEEP is what's going to open your alveoli and promote better gas exchange, okay? Really important to remind yourself that this blood flows by the gas units, the alveoli, dependent on right ventricular ejection. So one of the things that we have to always consider is the state of the right ventricle, how the right ventricle is managing its stroke volume, the amount of blood that the right ventricle ejects with each beat. It's also really important to remember that the pulmonary physiology and the pulmonary blood flow is the full cardiac output. The full cardiac output. So I may have good lungs, I may have ventilation at 5 liters, alveolar ventilation at 5 liters, but I might have a blood flow of 10 liters because I have a hyperdynamic cardiac output. My patient's in septic shock. So now V to Q, 5 liters to 10 liters. Okay, so 5 divided by 10 is going to be 0.25. I'm not looking at a calculator, so you can correct me if I'm wrong. But what that's going to do, is it's going to tell you that your perfusion is much greater than your ventilation, which means because you've got so much blood flow going through the pulmonary vault, overall, your blood gas is going to look poor because you're not oxygenating appropriately. Okay, so really, really important when we're thinking about this relationship for our patients. I also want to remind you that the lung is encased inside of a pleural cage, and the floor of that cage is the diaphragm. Now, that's really important to us because diaphragmatic function, of course, is integral to breathing. But also, whenever there's occupation of space in the abdominal vault, like abdominal compartment syndrome, the diaphragm will push up, and that will reduce the compliance of your lung. Now, remember, compliance is about alveolar recruitment. So anything, if I get fluid, if I get blood, if I get air in the pleural sac, that's going to compress my functional lung tissue, and it's going to cause a reduction in alveolar compliance. So really incredibly and profoundly important. Now, I really love this little visual. I just think it's such a great visual to just remind you about this pulmonary anatomy, that it is not just whether or not the alveoli are open, but it is also about the blood flow past the alveoli. You must have an optimized cardiac output in order to meet with the gas. Now, remember, the gas is called ventilation. Blood flow by is perfusion, ventilation V, perfusion Q. That is your VQ match. That should be 0.8. Anything lower than that means that you have inadequate perfusion to ventilation. So you have more ventilation than you have perfusion. That's a low VQ match. A low VQ match means you have more ventilation than perfusion. That is also dead space. I've got gas, but not blood. Okay. So whenever that occurs, compensation is going to begin. Whenever there's a mismatch, okay? So remember, the mismatch is that you could be impaired by perfusion, meaning you have a low blood flow. You could be impaired by ventilation, meaning you have a low gas flow. And basically, we can do a VQ calculation. Your monitors do a VQ calculation. But in general, what we do now today is a P to F ratio. That will be a question on your exam. It is in common practice for over 10 years. It's a question on the exam. P to F ratio takes the patient's PaO2 and divides it by the FiO2 in the decimal. Sorry about that. I think I'm going backwards. Okay. All right. So a really important concept is to understand what is the FiO2 that I'm delivering to my patient. Okay. So when I say to you, your patient's on 50% FiO2, what does that actually mean? Feel free, anybody on the call or in the classroom. I'm delivering 50% FiO2 to my patient. What does that actually mean? It's a fraction of what? Okay, excellent answers. Not quite right. It's percent of atmospheric pressure that is oxygenated. So that's the important content to understand. We live at 760 millimeters of mercury. So if I'm breathing 50% FiO2, that is 50% of 760, which is what? 50% of 760, so divide 760 in half, what is it? 380. That means I'm breathing a partial pressure. That is like such a basic foundational question that we all have to appreciate and understand. If I'm giving you 50% of atmospheric pressure, 50% of that is oxygen. I'm delivering 380 millimeters mercury partial pressure of oxygen into the alveoli. That creates a very big gradient, and oxygen should be very highly present in my blood. If oxygen is not present in my blood at that high FiO2, the gas never got to the alveoli, number one, or you don't have blood flow past. Number two, you cannot stand around accepting a PO2 of 80 when you're on 50, 60, 70, 80% FiO2. It means gas didn't reach the alveoli. You're going to treat that with PEEP. Or you don't have blood flow by. You're going to treat that with volume and inotrope. You cannot stand around. And on the exam, they will not ask you to stand around and wait. When you're titrating FiO2 up, you're increasing the partial pressure of oxygen here in the alveoli. And that should move into the blood as long as it ever got to the alveoli, which is the most common problem with ARDS, with pulmonary edema. You have alveolar de-recruitment, and the gas you're giving the patient doesn't get into the lung. So that's a really critical and important perspective. And that's really what helps us to define hypoxia, okay? Hypoxia actually means that I don't have adequate oxygen. So the first way I'm going to treat that is I'm going to go up on your FiO2. Now, remember I said before, we've got to consider the proportional relationship. The gas I gave you, did it get into your blood? Okay, now we can do a VQ calculation. No one's going to ask you to do that. It's never a question. It shouldn't be a question. It's complex. It requires a lot of different measurements. It's a pretty complex calculation. So what we use in today's world is the P to F ratio. And that's the patient's PaO2 divided by the FiO2. Okay, so for me, my PO2 is 100 and I'm breathing 0.21. 100 PO2, 0.21, has to be in the decimal. So my P to F ratio is close to 500. In our critical patients, what we're striving for is a P to F ratio of greater than 300. And we should never be accepting a P to F less than 150 to 200. So I have a patient who is poorly oxygenated, they're hypoxemic, they don't have appropriate oxygen in their arterial blood, and they have a P to F ratio of 100 or 125 or 150, and they're already on 80% FiO2. Do you have evidence that the gas you're giving the patient is not reaching the blood? Yes or no? Yes. Okay. So what are you going to think about? First, how do I open the alveoli? And second, how do I assure that there's blood flow past? That's what you have to do. So that's what we really talk about when you'll hear your docs and others will talk about shunt. Shunt means that you have blood that is going through the lungs that's not participating in gas exchange. You might have high dead space, you may have poor perfusion, but you are not having participation of gas exchange in your blood. That's the grandmother of gas exchange, okay? Remember, alveolar ventilation around 4, pulmonary perfusion about 0.5, so 0.4 and 0.5, and normal is 0.8. Low VQ actually tells us that we have shunt. High VQ tells us we have dead space. When I use the word low, it's describing the numerator, okay? Low VQ means ventilation not adequate for perfusion. High VQ means high ventilation and not adequate perfusion. Okay, so that's really important when we talk about VQ, because there will be a question about VQ. Low VQ means that you are not ventilated well enough. You have normal perfusion, but you're not ventilated well enough. Low VQ says ventilation is low. High VQ says ventilation is higher than perfusion. Okay, so in this case with shunt, what I'm going to try to do is increase my ventilation, my recruitment of my alveoli. I'm going to add P. And in this case with dead space, if I can, I'm going to reduce the ventilation, but that's probably not the answer. The answer is to probably increase the perfusion. Okay, so low VQ is shunt, high VQ is dead space. Does everybody have a basic understanding of this? You feel okay? Yes, no, maybe so? How you doing, my friends who are on here? Feeling okay? So remember, VQ is just about the relationship of ventilation to perfusion. Ventilation to perfusion. Okay? And that's what's really important here. And that's what we're always going to try to optimize. That's what we're measuring. That's what we're using blood gases for, to tell us where your problem is. So let's move to blood gas, because that's going to be the major component of the rest of our time together. Okay? I want to remind you that we're going to think first and foremost, we're going to think about oxygenation when we look at the blood gas. We're going to look at dissolved oxygen, that's your PaO2, but that is a very small amount of oxygen in the blood. PaO2 is the dissolved oxygen. That's the only oxygen that's usable. The only usable oxygen is the dissolved oxygen, which is why we care about looking at that number. Normal range is 80 to 100. It's going to be lower at higher elevations because the barometric pressure is lower, so the FiO2 is a lower amount of oxygen. Okay. Want you to remember that in older adults, there won't be any questions at all about infants, but that's okay. Just for infants, breathing room air have a much lower PaO2. For older adults, 80 millimeters mercury minus 1 millimeter for every year over the age of 60. So for me, if the norm is 80, I'm 70. Okay. So my normal PO2 is 70. Because I reduced 1 millimeter of mercury for every year over the age of 60. I'm 10 years over 60. So I have reduced by 10. 80 minus 10 is 70. That's my normal PO2. Anything that's abnormally low, we're going to consider hypoxemic. Anytime PaO2 is lower than 40, that is an emergency and it's life-threatening. In any age group, anything lower than 40 is an emergency and is life-threatening. So we're always going to pay a lot of attention to that. Looking at oxygenation is really easy. And we're going to use a couple of simple terms, okay? So remember, FiO2 is the fraction of the barometric pressure, the percent of barometric pressure. So again, living in Atlanta, which is sea level, it's 760. If you live in Denver, it's 680 barometric pressure. So by rights, those individuals are going to have lower PO2s because they live at a lower barometric pressure. Okay, so that's pretty important. I don't think there'll be any questions on that, but just remember, FiO2 is the percent of barometric pressure that is oxygenation. And then the P to F ratio, which is really what we think about today. Ratio of gas given is your FiO2 to the gas received, which is PaO2. So the P to F ratio, which is what we use today to help us look at patients. Okay, so pull your calculators out because you're going to calculate this. Okay, I want you to calculate it. So your PO2 is 70 and you're on 0.21. PO2 is 70 divided by 0.21. What's your P to F ratio? $70 divided by 0.21. What's your P to F ratio? You guys on the call should be doing this too. Well, I gave you the answer, but thank you. I want you to calculate it. Okay. So it's 333. Okay. Now you and I have 500. I'm worried about my patients when it's less than 200. So even though I might not love that PO2, I have a very good ratio. Now what that ratio says is that the gas the patient is breathing is getting delivered to the blood. What do I want to do? I want to increase their FiO2. Does that make sense? Okay. Take a look at this patient whose PO2 is 90 and on 30%. So that one's pretty easy. 90 divided by 0.3. P to F ratio is 300. I'm still okay, right? I'm a little higher FiO2, but I have a good gas exchange. Then I go over here. I have a patient with PO2 of 96. I'm leaving my shift today saying, Yahoo, look at what a great job I did with my patient today. I got his PO2 to 96. He's on an FiO2 of 50%. And his P to F ratio, 96 divided by 0.5, his P to F ratio is 192. That is not good. This is a patient with gas exchange failure. Although you're happy about the PO2 being 96, you have to then say the gas I am giving the patient is not getting into the blood. And there's one of two problems, or maybe both. Alveoli are not recruited, or I don't have good blood flow past the alveoli. Do you understand? I'm going to use that cutoff point. Really, at this point, I'm going to use a cutoff of 200. Okay. Then I'll look down at this patient whose PO2 is 80 and who's on an FiO2 of 80%. So 80 divided by 0.8 gives me a P to F ratio of 100. Okay. I may have worked all night to get that PO2 up to 80, but I am still not optimized. And I'm still going to have discussions about failure of optimization for this patient. Does that mean that everybody is going to bow down to me and say, thank you so much for pointing that out? No, but you are not going to report a PO2 of 80. You're going to report a PO2 of 80 and the P to F ratio. And you should never communicate about ventilatory management ever without including the P to F ratio. Now, your medical team, pulmonology team, they're going to be very attuned to the P to F. Others may not be quite as attuned to P to F, but let me tell you, it's been alive in clinical practice and the primary indicator of failure of gas exchange for over 20 years. So there's just no more excuses about why people don't use P to F regularly. I think in general, on your exam, there'll be, it won't necessarily ask you to calculate. They'll just give you the P to F, and they'll say that P to F is 90. Do you want to increase FiO2 or do you want to increase P? When your P to F is less than 200, the probability is your patient's not an oxygen responder. You got to open up the lung. So when P to F is less than 200, think about lung opening, and lung opening means actually applying PEEP. Sorry, guys. Okay. No, normal P to F should be greater than 300, but for us, it's going to be somewhere between 400 and 500. If I have great lungs, I'm intubated, I come out of the OR, I have great lungs, and somebody left me on 100% FiO2 and I have great lungs, my PO2 is probably going to be somewhere around 560. Because I have good gas exchange, I have good blood flow, right? That's why you don't blow 100% at everybody, because they don't need it. And as soon as you evaluate that patient, so as soon as we intubate patients, we have them on 100% FiO2, we do the first blood gas and immediately titrate the oxygen down because they have good gas exchange, right? So that's really important. So again, P to F is just a simple method to actually say, did the gas I give the patient get into the blood? So always want it greater than 300, but now we talk about it as less than 250, less than 150, less than 100, and with PEEP on board. Okay, so this is how we look at ARDS. It doesn't mean that every patient who has a poor PF ratio has ARDS. That's not true. We can just have respiratory failure and have failure of gas exchange. But we're going to use P to F to quantify how much failure you have. We're going to use P to F to quantify whether or not patients are responding to PEEP. So as I go up on PEEP, I'm going to expect your P to F to improve because I've opened up your alveoli and I have better gas exchange and better recruitment. Okay. All right. Now you do have to take out, well, this is the same thing as we looked at already. So this is how it looks. Okay. So this is normal. Alveoli is nicely recruited. It's fully developed, good gas exchange and blood flow pass in an adequate potential. Okay. In shunt, remember, we have blood that passes through the lung without getting oxygen because we're hypo-recruited, not just hypoventilated, but our alveoli is not recruited. So we might have obstruction to gas flow. We could have narrowing of our airways. We could have underventilation. We could have pneumonia. Our alveoli are not recruited, so blood passes through here without getting oxygenated. Over here is your dead space. Your alveoli is over distended, but you have inadequate blood flow past that. So very straightforward. This is called high VQ. Ventilation is high in relationship to perfusion. This is called low VQ. Ventilation is low in relationship to perfusion. Now, there are always going to be questions about VQ, always, because it's such an important strategic point for us to appreciate and understand. And so that's why we talk about this. Okay, we're done with that. So we're looking for normal oxygenation, normal saturation, and a normal P to F. That tells us all about oxygenation. But now we got to think about CO2, which is really an important component. And it also is one of the earliest predictors of respiratory failure. Carried in the blood, CO2 carried in the blood basically in three ways. Number one, dissolved in the plasma, that's the smallest amount. That's the partial pressure of carbon dioxide dissolved in the plasma. Combined with hemoglobin, you're not usually looking at the hemoglobin combination of CO2. That's very high in the venous bed. The majority of CO2 is carried bound to hemoglobin in the venous bed. We're not going to worry about it. We're just really thinking about the dissolved state. And then the third is by binding carbon dioxide to water, that yields what we call carbonic acid, H2CO3. Carbonic acid yields ultimately hydrogen, which is the metabolic acid and bicarb. Okay, now this process right here, this process requires kidney function. So if I'm retaining CO2, I'm not able to exhale my CO2 and my CO2 goes up, I must have a normal kidney function to convert that CO2 ultimately to bicarb. That is done at the kidney. That's called a conversion reaction. It requires a functional kidney. So by the way, when you have AKI and acute respiratory failure, you go down really quickly because you don't have compensatory capability. You don't have kidney compensation and you don't have lung compensation. So you go down the tubes pretty darn quickly. Requires kidney function to convert carbon dioxide with water to ultimately to hydrogen and bicarb. The kidney wastes hydrogen, which is the metabolic acid, and retains the bicarb, which is why in chronic lung patients who have high CO2s, but a relatively normal pH, when you look at the bicarb is elevated. That's their compensatory mechanism, but it requires that they have effective kidney function. When they come into your ICU and they develop AKI, they will deteriorate very, very rapidly. Okay, so really important to remember, and the amount of carbon dioxide, of course, in the blood is going to determine acidity and the pH. So any questions to where we are right now? Guys on the chat, feel free to ask a question. Folks in the room, feel free to ask a question. No, everybody good? You're feeling pretty good with what we've said so far? All right, excellent. Okay, wait, might have a question. Okay. Thank you, Derek. All right, so now we're just going to think about our normal arterial blood gas, and this is the basic normal ranges, right? Normal range, pH on the acid side, 7.35, and on the alkaline side, 7.45, but this range is normal. For those of you who are not excellent in blood gases, I want to give you a couple of really good important cues. Whenever you start with the blood gas, you always look at the pH and you look for a perfect pH. Perfect pH is 7.40. Anything below that, whether it's in range or out of range, anything below 7.40 is on the acid side. Anything above 7.40 is on the alkaline side. Okay, so you always start with perfect pH. Anything below that on the acid side, anything above that on the alkaline side. Then we look at PaCO2, and in the arterial bed, the range of PaCO2 is 35 to 45. We're going to look for perfect. Perfect PaCO2 is 40. Anything lower than that is on the alkaline side, so exactly opposite of the pH. Anything lower than that is on the alkaline side. Anything higher than that is on the acid side. PaCO2 is a direct acid, and it's a direct acid measure. We've already talked about the PO2. Also, saturation is the reserve of oxygen that's bound to hemoglobin that will come off the hemoglobin and dissolve in the blood to be used. Then we think about bicarb. Okay. And when we talk about bicarb, perfect bicarb is 24. The range is 22 to 26. But what I want you to remember, and it will bode well for you, if you look at bicarb and base, the direction of the bicarb and the base is an opposite reflection of metabolic acid. In other words, if base is in deficit, if bicarb is down, metabolic acid is up. That's what you have to remember. You can memorize all the mnemonics you like, but you've got to understand this. Bicarb and base are actually the partners to metabolic acid. When metabolic acid goes up, you are going to bind your base, you're going to bind your bicarb. They are no longer valuable in the blood. Base is in deficit, bicarb goes down. That always means metabolic acid is up. Okay. Carboxyhemoglobin is probably the one that you might be asked a question about, and that would be, you should always be less than 3%. Methemoglobin, these are abnormal forms of hemoglobin, either carbon monoxide bound to the hemoglobin, which displaces your oxygen, or an alteration in the hemoglobin integrity. So we're just going to remember those numbers. They're not going to typically be any questions that you will be asked. Okay, so that kind of takes care of the blood gas. This is called the content of arterial oxygen. In the old days, you might be asked a question about this. You probably not, but I'll just explain. Content of arterial oxygen is the amount of hemoglobin saturated with oxygen and the amount of oxygen each hemoglobin then carries. So sometimes we have discussions about it, particularly in trauma surgical patients. Content of arterial oxygen, I'm just going to give you the formula, and actually, if I can escape this, I will. Okay, so let me just give you this basic formula. If it allows me, it's not going to allow me to edit, I guess, because there's not a Microsoft PowerPoint here. So I'll just tell you what it is. Hemoglobin times SAT in the decimal. So patient's hemoglobin times their arterial SAT in the decimal times 1.36. Hemoglobin times SAT times 1.36. That actually yields content of arterial oxygen. Now, the normal content of arterial oxygen is 16 to 22. So let me give you what that formula is based on. You're going to need to pull out your calculators. Okay. And unfortunately, I can't manipulate the slides on this program. Okay. So hemoglobin is, I'm going to give you something easy. Hemoglobin is 10. Saturation is 100%, so that's 1.0. So 10 times 1.0 is 10 times 1.36. 13.6. That's your arterial content. Normal arterial content is 16 to 22. So is your content already low? Yeah, because you're at 13.6. Your arterial content is low. Now, these content numbers were based on hemoglobins of 14. So that's really important to remember. So when you look at a textbook definition or someone says his content is low, be aware that content numbers were based on old hemoglobins of 14, which is what we used to consider to be normal. But when I have a patient who has a hemoglobin of 8 at 100%, okay, so 8 at 100%, times 1.36 the content of oxygen is life-threatening. So you do actually want to be aware of this. I don't think the exam is going to ask you at this depth. It used to be very common, but I think people had a lot of struggle with those questions, so they got rid of the questions. But in your clinical practice, remember, oxygenation is about the reserve of oxygen that you have. That's your hemoglobin times SAT, and the amount of oxygen each saturated hemoglobin is carrying, which is 1.36. So very, very important. Now we're going to move over here from basic blood gas to another method of evaluating carbon dioxide, and that would be your end-tidal CO2. So I like to remind everybody when we talk about CO2, what you look at in general is how much carbon dioxide is in the arterial blood. And that is, from my point of view, it's very important, but from my point of view, it's the least important. Number one is the production of CO2. That happens at the cellular level, and that gives rise to the measure PV-CO2. Number one, how much CO2 are you producing? Number two, how much CO2 are you eliminating? ET-CO2 is end-tidal, but I also want you to think about the E for elimination. End-tidal CO2 is the elimination of carbon dioxide through ventilation. Arterial CO2 is what's left over. After you produced and eliminated, what's left over. Okay? So when we're looking at a blood gas, we're looking at what's left over. But is our problem elimination or is our problem production? Elimination is a ventilation problem, and you're going to address that with mechanical ventilation, or you're going to address it with promoting exhalation. However you do that. Maybe you give inhalers, maybe you increase your IPAP on your BiPAP device, or you increase your tidal volume because you've got to eliminate more end-tidal CO2 if it's a ventilation problem. But if it's a production problem, you have to increase cardiac output. That's it. It's so straightforward. We hang so much of our hat on that PaCO2, and we always assume that that's a ventilation problem. So we always attack using the ventilator. We're not looking at the production. Okay, so PaCO2 is the gas that's left after you've produced it and eliminated it. What's left over is what you see in the arteries. Does that make sense to everyone? Okay, so normal PaCO2 by our blood gas, 35 to 45. I think I probably have that here. No, probably not. Okay. Normal PaCO2, 35 to 45. That's the one you have to know. That's the one you have to know. You got to memorize that. Can't let go of it. 35 to 45. Lower than perfect, which is 40, means that you are eliminating more CO2 and you have less CO2 in the blood. Good. So I'm hyperventilating. Higher than that means either my production is high or my elimination is poor. Okay. 35 to 45 for PaCO2. I'm going to add 5 to either side of that. So 35 to 45, that's the one you have to remember. Add 5 for normal PV-CO2, which means normal PV-CO2 is 40 to 50. So 35 plus 5 is 40. 45 plus 5 is 50. Normal PaCO2, 35 to 45. Normal PV-CO2, and pay attention. When you're looking at lab values on an exam, pay attention. Make sure it says A or B. Or they say it was drawn from the artery or drawn from the vein. Because you're going to expect PV-CO2 to be a little bit higher, normally 40 to 50. And lots of times we do a venous sample because we can't get an arterial sample. So we got to understand that. End-tidal CO2, subtract 5 from either side of PaCO2. That's the one you have to remember. End-tidal CO2, 30 to 40. PaCO2, 35 to 45. Add 5 for venous, 40 to 50. Subtract 5 for end-tidal, 30 to 40. Good? 30 to 40. No, end-tidal CO2 is eliminated. End-tidal, if you see the letter E, it means end-tidal, and I want you to remember elimination. I'm blowing out that CO2. That's elimination. Okay. When I hyperventilate, my arterial CO2 goes down because I blew more off. But here's the thing, that this is the question that gets everybody and that causes problems for everyone. End-tidal and arterial CO2 should always go in the same direction. So what you actually are looking at is the time it takes to exhale your CO2. That's how you measure end-tidal CO2. So when you're hyperventilating, you're clearing overall more CO2, but you're taking less time to get rid of it. So when I'm hyperventilating, my PA CO2 is 30, my end-tidal CO2 is probably going to be 28 or 25, because arterial and end-tidal should always go in the same direction. The number one reliable bedside sign, and that's only if you have a calibrated and effective end-tidal CO2, the number one reliable sign of pulmonary embolism, number one, is end-tidal CO2 is down and arterial CO2 is up. Reliable sign in PE, and oftentimes the question that's asked by the AACN, your end-tidal CO2 is 28, your PA CO2 is 59. Did they travel in the same direction? No. In order for me to clear CO2, I must first have alveoli that are functional, and second, I must have blood flow by. If I have a pulmonary embolism, I have obstructed blood flow. So my blood goes through the lung without ever being processed. So my CO2 in my blood is high, but my end-tidal is low. That is diagnostic for pulmonary embolism. At least, there are other things, but that's the main one. Okay. What do I have? Dead space or shunt? Okay, let me say it this way. What do I have? High VQ, dead space. Low VQ, shunt. Okay. Is the problem with recruiting the alveoli? Do you know that? Or is the problem with blood flow? If I have a pulmonary embolism, what's my problem? Blood flow. So what's actually going down? Effective perfusion has gone down. So I have dead space. I have alveoli that are ventilated, but I'm not flowing blood past those alveoli because I have a blood clot. Good? It'd be a high VQ, and that's dead space. Okay, is blood going through without getting oxygenated? Some, but actually I have a significant reduction in blood flow going through the pulmonary vault because I've obstructed it, right? So the thing that's affected most is my perfusion. Now I see that a lot where PA CO2 is high and end-tidal is low. Remember, you have to be sure your equipment is operational. And remember that in the list of answers, always answer the one that seems the most right. But in this answer, the answer might be, you want to increase your patient's tidal volume and respiratory rate. Is that the answer? In a pulmonary embolism, is the answer to increase tidal volume and respiratory rate? Is your problem the lung? No. Is your problem your blood flow? Okay, so what do you want to do? You want to go to the cath lab. You want to have a thrombectomy. You want to give TPA. You want to give an ECOS. You want to get rid of the blood clot. Treating that patient with ventilation isn't going to give them improvement, right? Because that's not their problem. That's how we use this. We have to understand how to use this. You can't just memorize it. Okay, PVCO2, what you produce, EtCO2, what you eliminate, arterial CO2, what's left over. End-tidal and PaCO2 should always travel in the same direction. So if my PaCO2 is high, my end-tidal should also be high. If my PaCO2 is low, my end-tidal should also be low. When end-tidal is low and arterial is high, that is the very definition of obstruction to blood flow through the pulmonary vault, and the most common cause is pulmonary embolism. Good?
Quick question on the PVCO2. How is it produced again?
It's produced by cellular, it's actually cellular respiration. CO2 is a byproduct of breaking down of glucose substances.
How is it measured directly?
In a venous blood gas. Yeah, so, you know, whenever I see somebody with a high arterial CO2, I always want to look at venous CO2. So I'm going to draw an arterial gas and a venous gas at the same time. And you always do that comparative analysis, and it is measured directly. Lots of times all you have is a venous sample. Okay. Problem is with a venous sample, let's say you drew a venous sample and your venous CO2 was 60, well, that's higher than normal. Is the problem production, or is it just failure of elimination? You can't answer that question. You have to have an arterial CO2. So now let me ask you a question. There might be some questions that come up later. Okay, so PVCO2 is 60 and arterial CO2 is 55. Is the problem production or elimination? They're both high. And the difference between them is only 5, which is a normal difference. They're both high, and the difference between them is normal. So what does that tell you? You're not eliminating. You want to treat that with mechanical ventilation. Okay? If my venous CO2 is 60 and my arterial CO2 is 30, what do I think now? Venous CO2 is 60 and arterial is 30.
You're eliminating too much.
If your venous CO2 is 60, is that normal or high? Okay, your arterial CO2 is 30. You're eliminating a lot, but why are you eliminating a lot? Because you produced too much. Okay, so you go in that room and the patient's breathing 35 times a minute, but he's doing that because he's blowing off CO2 because you're producing too much CO2. You stop him from breathing, from breathing so fast, he will quickly plummet into an acidotic pH. He's got to eliminate that CO2 that he produced. So now let's add the end-tidal, okay? So PVCO2 is 58, arterial CO2 is 50, and end-tidal CO2 is 48. Do you want to treat your patient with ventilation, or do you want to treat them with perfusion? Yes, because your patient is hypoventilated. They're taking a long time to clear the CO2, which is why that number is high. You need them to move more CO2, so you're going to treat them with ventilation. Okay. Patient has a CO2 of 60, PV CO2 of 60, an arterial CO2 of 40, and an end-tidal CO2 of 35. Is your ventilation okay? Yes. Is your arterial CO2 okay? Yes. What's your problem? Your venous CO2 is high. What's your problem? Are you producing too much or too little? producing too much. You're going to treat that one with perfusion. Okay. Are you totally and utterly confused? I can't tell. Yes. Are you good? I couldn't tell. You're hungry? Oh, I thought I'm hungry. Okay, everybody's got it. It's pretty important. The most important thing to remember, end-tidal CO2 and for your exam, not for your clinical practice, but for your exam. End-tidal CO2 and PA CO2 should always travel in the same direction. If PA CO2 is high, I expect end-tidal to be high. That's hypoventilation. If CO2 is low and if end-tidal is low and arterial is low, your patient is hyperventilated. Okay, both high, hypoventilation, both low, hyperventilation, and tidal low and arterial high, failure of pulmonary perfusion, indicative of obstruction to perfusion, most commonly pulmonary embolism. Good? Does that make sense to everyone? Excellent. Okay. So always really important to remember that CO2 occupies space in the alveoli. And because CO2 occupies space in the alveoli, when CO2 goes up, that is going to affect the amount of oxygen that is going to be communicating. So let's just say, I'm making it up, I have space for 100 molecules of gas in my alveoli. Normally, the occupation in the alveoli of carbon dioxide normally at rest is about 10. That means I have 90 slots for oxygen. But as I start to occupy more space with CO2, so I went from 10 to 50, that means the spots I have for oxygen goes down. Does that make sense? It's a very simplified way of looking at it. There's only so much space available for dissolved gas. And as your CO2 goes up, you're going to occupy more space with CO2 in the alveoli, and that's going to make less space available for oxygen. So that's one of the most important things that we talk about when we think about our blood gas and CO2 retention, is that when we're retaining CO2, that will displace oxygen. And that's why when we look at respiratory failure, we try to determine, do you have hypoxemia because you have a primary hypocarbia? Or do you just have standard hypoxemia and not really hypocarbia? That's really the way we're going to look at our patients. We're going to look at their blood gas, their normal blood gas, and look for the presence of CO2, the presence of oxygen, and the effect on the pH. We're going to remind ourselves that saturation is the reserve oxygen that's available for use, but it must come off of the hemoglobin and dissolve in the blood, yielding PaO2 so it can be used by the cell. That base and bicarb are the direct opposition of metabolic acid up, base and bicarb down. Okay, so. So we're going to do blood gases now. So hopefully that will help clear it up. Okay, but what? No, they're not the same. Bicarb is the major buffer. Base is a calculation of all circulating buffers. So base tells us about other buffers other than bicarb, but bicarb is the main buffer. So they both will go down when you have an increase in metabolic acid, not CO2, metabolic acid. They'll both go down. That means metabolic acid is up. Okay. All right. Good. All right. So when we talk about a blood gas, the number one thing we do is we determine oxygenation. That is really, really, really easy, right? We look at your PaO2, remembering that normal is 80 to 100. There's some caveats. You're a newborn baby, you're an older person, but normally 80 to 100 is the dissolved oxygen. That's the oxygen that can be used by the cell. You must be dissolved to be used by the cell. It can't be bound to the hemoglobin. Saturation in hemoglobin tells us about reserve oxygen. Now, if my cells are using a lot of oxygen, the hemoglobin will release its oxygen to dissolve in the blood to be used by the cell. Okay, that's really important to understand. So saturation of hemoglobin is reserve oxygen. It can come off the hemoglobin, dissolve in the blood, and be used by the cell if the cell needs it and if the cell can get it. Okay? So typically we say 95 to 100%. That's what the textbooks say. In clinical practice, we really don't worry much until your SATs drop below 90%. Depending on the patient, if they're a chronic lung patient, I'm not going to worry until they drop below 88%. But 90% is what we're going to use our general frame of reference. Okay. And remember, panic PaO2, no matter what your age is, anytime PO2 is less than 40, it's time to panic. Okay, that's a panic PaO2. Okay. Step 2, I want you to look at your pH, and I want you to think about pH as perfect. Perfect pH 7.40. If it's below 7.40, doesn't have to be out of range, but if it's below 7.40, that means you may have a little more presence of acid. If it's above 7.40, it means you have a little less presence of acid, you're more alkaline. So start with the perfect pH and then move to step 3. Look at your CO2. CO2 is perfect, that's 40. Okay. CO2 is down, that's on the alkaline side. If CO2 is up, it's on the acid side. Again, we're not talking about the range, we're just talking about directions here. CO2 is up and pH is down. They both might be in range, but you have a reflection of the state of acid in the blood. So CO2 is 44 and pH is 7.39. You're on the acid side of perfect on your pH, and you're on the acid side of perfect of CO2, but you're still in the range of normal. This is not abnormal. It just means you have a little extra acid, and it's reflected in the pH and in the CO2. And then we go to bicarb and base. Okay, so I think people have the most trouble with bicarb and base. Bicarb and base, perfect bicarb is 24, perfect base is 0. Bicarb is a direct measure or a calculated measure of the circulating bicarbonate. Base is a calculated measure of the circulating buffers. But in either case, when you look at bicarb and base, if they are down, metabolic acid is up. If metabolic acid is up, your pH will reflect that by going to the acid side. Does that make sense? Don't think about bicarb and base. Translate bicarb and base, both or either one. Translate that to metabolic acid. Metabolic acid always is in the opposite direction of bicarb and base. The sole purpose of bicarb and base is to neutralize metabolic acid. Sole purpose. So when base or bicarb neutralize metabolic acid, they are both taken out of the circulation, and my measured bicarb and my base go down. So bicarb goes down, base is in deficit because they've neutralized acid and become a different compound and are now taken out of the circulation. Okay, does that make sense? And you're good with what I just said? Okay, excellent. Okay. And then step 5 is you got to match the component that's causing the pH change, and that's what you're going to name it. Okay. So if CO2 is up and pH is down, that's respiratory acidosis. If bicarb is down, which always indicates an increase in hydrogen ion, metabolic acid, and the pH is down, that's metabolic acidosis. Right? That makes perfect sense. If CO2 is up and bicarb is down and your pH is down, you have both respiratory and metabolic acidosis. If CO2 is low and pH is up, CO2 is low and pH is up, that's a respiratory alkalosis. If bicarb is up and the pH is up, that's a metabolic alkalosis. So you're naming direction, up or down, acidosis, alkalosis, by the pH. And then you're looking for what caused it. It's either going to be respiratory, CO2, or metabolic, which is hydrogen ion disguised as bicarb and base. Good? All right. So this is how I teach this. Perfect measures. CO2 40, pH 7.40, bicarb 24, base 0. And then the range. The green color reflects alkaline, the red color reflects acid. And I find this is the easiest way for folks that maybe are not experts yet in blood gas interpretation, because kind of understanding always start from perfect. That will always tell you the story. Okay, so when we just think about our pH, pH is a symptomatic reflection of the presence or absence of acid. That's what it is. A symptomatic reflection. I have respiratory acid CO2 and I have metabolic acid hydrogen, but we don't measure hydrogen, so we look at base or bicarb to reflect that hydrogen. Okay, so my metabolic acid is up. The correspondent to that is base and bicarb. Those are down. My pH is down. I have a primary metabolic acidosis. And what I ultimately want to see happen, hoping I have it, is that I'm going to blow off my respiratory acid in order to compensate and get my pH back to a acceptable range. So what has to happen on the opposite side, the non-problem side, is to do the exact reverse of what the pH is. So if the pH is acidotic and it's metabolic acidosis, I have to blow off CO2 to compensate. Does that make sense? Okay. If I have an increase in CO2 because I have a ventilatory failure, my pH goes down. And what's going to happen is my metabolic acid must go down and my base and bicarb must go up in order to compensate my pH. So that's what you see here. Simple cartoon. Okay. All right. Number one, you have to write the answers down. I'm not going to tell you the answers. We're going to do all 4 of these. You're going to do them. So I'm going to just run through the first one. And this is the way I think is helpful to look at it. pH is 7.55. Perfect? Yes or no? Up or down? Inside, outside range? Okay. Do you have a significant problem? It's outside range and it is alkalotic, correct? Everybody good? All right. Now I look at my PaCO2. PaCO2, perfect. Yes or no? Up or down? Inside, outside range? Okay. So do I have a primary respiratory alkalosis? Yes or no?
Yes.
Yes. Okay. PaO2 is 80, bicarb's 29, base is 6. Primary respiratory alkalosis. But what I would have expected is that I would be retaining metabolic acid, but instead my bicarb and base are also up. Bicarb, perfect is 24. Am I perfect? Range is 22 to 26. Am I inside range? Am I above or below? And that is also, that means metabolic acid is down. That is also alkalotic. So what do I have here? A mixed respiratory and metabolic alkalosis. Everybody okay? All right, let's go to the next one. pH 7.25. Perfect? Up or down? Inside, outside range? Outside range. So I've got a significant problem. That means I don't have compensation. That's what that means. I've got a significant problem. That problem is acidosis. PaCO2 is 56. Perfect. Up or down? Inside, outside range? Do I have a respiratory acidosis? So I've named problem number 1. I've got to go to the next level, but I've named one problem. I've got a primary respiratory acidosis. I go over here, PaO2 is 80. Doing pretty good. Bicarb is 15. Perfect. Yes or no? Okay, perfect bicarb is 24. Perfect base is 0. Am I up or down? Down, which means my metabolic acid is? No, metabolic acid is up if my bicarb and base are down. And are they inside or outside range? Okay, do I have metabolic acidosis? Do I have respiratory acidosis? Do I have mixed respiratory metabolic acidosis? Everybody feels okay? All right, next one. 7.36, perfect, yes or no? Yes or no? Okay. Inside out or outside range? But it is down, so it's on the acid side. Okay, now that could be a normal variation. I just have a little excess acid, or it could mean I have acidosis with compensation. So let's look. PaCO2, perfect, yes or no? Is it up or down? Inside or outside range? Do I have respiratory acidosis? Okay, now I see that reflected in the pH because the pH is on the acid side, but the pH is in the range of normal, which means automatically I already know that the other system has done what? Compensated. So now I go to my bicarb. Perfect, yes or no? Up or down? Inside, outside range? Okay, so bicarb is up and outside range, base is up and outside range. That means my metabolic acid is down, 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 which is how I compensated for my primary respiratory acidosis. That's why my pH is in a normal range. So here I have what we would call historically a compensated respiratory acidosis. In today's lingo, and I can't tell you which lingo is going to be on the exam, it would be chronic or compensated respiratory acidosis. Time enough to compensate. We no longer use terms like partially compensated. We either say you are acute, which means pH is out of range, or chronic, which means pH is in range. This is chronic. This is what? Acute. This is acute. If it's outside of range, if pH is outside of range, it's acute. Good? All right, now we go down here. Oh, you know what? I'm going to give you one more on this patient. So you'll have to write it down if you want to remember. This is the same patient as number three. Number three. pH 7.28. PaCO2, pH 7.28. PaCO2 60. PaO2 75. Bicarb 27. Base 2. Okay, so now we have to compare the patient. Here, he was chronic because he was compensating. But what's happening to him now? Is he still compensating or is he losing his compensation? He's losing his compensation, which means he is starting to present with metabolic acidosis. And this is what happens to all your chronic pulmonary patients who have secondary problems, infections, trauma, sepsis. They come into the hospital with a compensated blood gas, and then they quickly lose their compensation. Their bicarb and their base are still elevated, but not as elevated as they were before because they are starting to decompensate. Does that make sense? Yes? Okay, good. So last one, pH 7.38. Perfect, yes or no? Not perfect. Up or down? Down inside or outside range? Within range. So it could just be a normal variation or you could have a problem. PaCO2 is 28. Perfect, yes or no? Up or down? Inside, outside range. So I'm blowing off CO2, which means I have less respiratory acid. So I already know I've got a problem. I already know I've got a problem because I have an alkaline CO2, but a pH that's on the acid side. That problem, I'm going to go all the way over here. Bicarb is 12. Perfect, yes or no? Up or down? Inside, outside range. And the metabolic acid then is up. If bicarb's down, metabolic acid is up. What do you have here? Name the problem. Is it respiratory or metabolic? Metabolic. And is the problem acidosis or alkalosis? Okay, metabolic acidosis. Acute or chronic? Chronic because you've had time to do what? Compensate. Okay, excellent. Perfect. All right. Pretty good. Okay, your assignment before next week, it's now 10 o'clock. So your assignment before next week is I would like for you to look at 10 patients who have abnormal blood gases, write down their blood gases, evaluate them, and make a recommendation about what you think should happen. And you're going to turn that in to me. If you guys are going to be virtual, you're going to scan it and send it to me or upload it into the chat column. You can upload a PDF. So you can upload a JPEG or you can upload a PDF, but I want everybody to turn in 10 blood gases next week with diagnosis and proposed intervention. Okay? Excellent. And also your P to F ratio on every one of those patients, a P to F, and is it high or low VQ match? Because the only way that you embed this in your head is if you do it all the time. All right. Very good, my friends. Thank you very much for coming today. We'll see you next Wednesday at 8 a.m. sharp. And we will continue on with pulmonary mechanics. All right. Thank you very much. Thank you for sharing today and for being here today. And we'll see you soon. Bye.